Capnography is used to measure exhaled CO2. In the intubated patient, a patient who is either in respiratory or cardiopulmonary arrest, capnography is used as a measure of their gas exchange or perfusion status. In a patient who has no perfusion or CPR is in progress, it's a measure of the effectiveness of CPR. Or when a patient gets a return of spontaneous circulation, or ROSC, it tells us immediately that pulses have returned. But primarily, the most important thing that capnography is used for is it will tell us exactly if exactly the point at which a tube has been dislodged. So what we say is there's no shame in accidentally placing a tube in the wrong hole. The shame comes in arriving at the ER with it undetected. Absolutely unacceptable to arrive with a tube in the esophagus undetected, and capnography will tell you the second that the tube has become displaced. Capnography is important in patient assessment because it really helps you reassess a patient. During a cardiac arrest situation, perhaps whether you're at the house or transporting a patient, things are hectic and there's a lot of information that the paramedic or EMTs are receiving. They need to look at rhythms, they're looking at effectiveness of CPR, they're looking at quality of ventilations. And that numerical value and the waveform provided on the capnography device will tell you so much. It tells you whether the person that's bagging or ventilating for you is going too fast or too slow. Just with the number on the capnography, we can tell whether that person needs to back off and bag a little slower, or whether they need to pick it up and give the patient a couple of additional respirations. And again, about circulation will tell us immediately when the person gets pulses back, and that will give us an indicator of how likely this patient is to be resuscitated. On the flip side of that, when a person's numbers persist in the single digits, so we're talking about capnography numbers somewhere between 0 and 10, if we're during the resuscitation never able to get their numbers above 10, we know that that patient is probably not going to be resuscitated. And many folks are going to adopt that as one of the indicators that helps us know when it's appropriate to terminate resuscitation. You know that resources are at a premium, and there's an increased risk in really transporting dead bodies or patients who are not to be resuscitated. And this is one tool that will really help us know matter-of-factly which patients really are appropriate for termination of resuscitation in the field. The graph becomes very important in breathing patients. So we've been talking mostly about the non-breathing patient who's in respiratory or cardiac arrest, but there is such a thing called side stream capnography used for breathing patients who are not intubated, and it really essentially kind of connects through a nasal cannula or non-rebreather, whichever device you're using, and can give you a lot of information about the quality of respiration, quality of perfusion, and gas exchange. And so you can look at the waveform and tell whether you have a COPD or an asthmatic, somebody that perhaps needs your assistance. And one of the decisions that's been very difficult for paramedics is when to intubate. They perhaps have kind of known that they're going to need to. Let's think about an anaphylactic patient, a burn patient, somebody with airway involvement, a CHFer who's working very hard to breathe. Many paramedics know they're going to have to, but that decision about when is so difficult. With side stream capnography, will really lead you to that decision more quickly to say, okay, I see that the effectiveness of cellular respiration is so poor here, we really need to assist the patient. Capnography is a different tool than pulse oximetry. Pulse oximetry is really measuring whether the patient is well oxygenated. So do you have on supplemental oxygen, and is the patient breathing, or are you breathing for them? That's what a pulse oximetry reading will give you. Many folks think that if you're using capnography and side stream capnography, that it will replace pulse oximetry, or certainly be an additional tool to use in that place. Pulse oximetry will give you a measurement of how saturated the tissues are, but capnography gives you a measure of gas exchange. So if you're carrying around oxygen, use this example. If you have bled onto the pavement, you have a trauma patient who's bled all but one red blood cell, and it's well oxygenated well saturated with oxygen, the pulse oximetry reading is going to be 100%. But we know that that patient is not in good shape because they've got one red blood cell left. So capnography would tell us that perfusion is actually horrible here, and that the person is in big trouble. Now, I've used an extreme example of one red blood cell, but you can see how pulse oximetry could lead you in the wrong direction if you're not understanding what it's measuring. Capnography here really gives you a better picture of the patient's perfusion and cellular respiratory status. Capnography absolutely must be used on all intubated patients and really is becoming the standard of care. Most systems, and in fact the system I work in, is mandating that if you buy a new piece of machinery, so they're not saying that folks have to go out and buy capnography, but when you replace your monitors, it must have capnography on there. So that's how important it is. Folks are saying all intubated patients should have the benefit of capnography. So that's important. Now, the folks that are really forward, really progressive, are using it on breathing patients in that side stream capnography capacity. End-tidal CO2 is the measurement of carbon dioxide in expired air. Now you can measure that in either a breathing or a non-breathing patient, and of course your numbers are much better in the patient who is breathing. My and your numbers right now are going to be 35 to 45. That's a normal capnometry reading, 35 to 45. When numbers get high, they start to tell us things about a CO2 being retained, meaning the patient's having a hard time exhaling, or we've got a gas exchange problem. So you might see a near drowning patient have a high CO2 level because they're hanging on to that. It's hard for them, once you get edema or fluid in the lungs, it's hard to get the CO2 out. Well, that's going to tell you something about this person's blood gas levels because they're hanging on to that CO2. It's what we call hypercarbic, and that's not obviously good. CO2 is an acid. When you hang on to it, it hurts the body's tissues. When you have low CO2 numbers, typically it tells you something less than 35. It typically tells you the patient is blowing off too much CO2, maybe somebody who's hyperventilating. You've seen a patient maybe who has an emotional situation and begins to hyperventilate. You're going to see lower than 35 on their capnometric readings. The person who has poor perfusion is going to have much lower. So in fact, one of the ways that we measure effectiveness of CPR in a cardiac arrest situation is to watch those capnography numbers. If the numbers are in the, say 20s, you tell your person that's doing CPR, do better CPR. Compression should be deep, fast, and hard. And either they're getting tired or they're afraid of breaking ribs or something is happening. You tell them either switch rescuers or give me better CPR. When you have really low numbers, remember, that's an indication the patient probably won't be resuscitated. Now, one of the most important readings is the zero or the near zero number. That tells you in the intubated patient that your tube is not in the right hole, that your tube is in the esophagus, not the trachea, which you know immediately to check that. I wouldn't say pull the tube immediately because you may have some mechanical failure. You may have a chunk of aspirate at the end of the tube. So I'm not saying pull the tube. What we're saying is you get a zero reading, there is no gas exchange taking place. So check. I would do another direct laryngoscopy and look to see if your tube is still between the cords. Make sure it's not in the right mainstem bronchus. Make sure there's no mucus plug on it, and check to see if you can't problem solve that and you remain at a zero level, you must remove the tube because you do not have confirmation of tube placement. I do think it should be a standard assessment tool. It is the single way we have right now, the only way we currently have to tell immediately when a tube has been dislodged. In the past, we've relied on lung sounds, condensation in the tube, chest rise. All of those clinical signs are very subtle and in the back of a moving ambulance are going to be very difficult to assess. So what you have are tubes that are dislodged in the movement from the ground to the stretcher, or from the stretcher to the back of the ambulance, or you have somebody that's assisting ventilations and lets go of the BVM and the weight of the BVM dislodges the tube. A movement of just a couple millimeters will remove the tube from the trachea and displace it in the esophagus. And what you find as a common phenomenon is that when people have moved the tube, when you have an assistant who has moved the tube, they're scared to death to tell you so they try to push it back down to where they think it should go, not realizing that it's not still in the right hole. It's no longer in the trachea. And so it may take you a couple of minutes to recognize that the patient's skin signs are getting worse or not improving, that perhaps you don't have good chest rise. You can imagine in the back of a moving ambulance, it's difficult really to see a lot of good chest rise. So with the use of end-tidal CO2, you will know immediately that the tube has been dislodged because when you had a waveform, it's going to go to a flat line. Paramedics are very good at recognizing flat lines, and in fact, EMTs are pretty good at recognizing that's a problem. And so it prompts you to reassess immediately. A couple of seconds with a tube in the wrong hole isn't going to be so harmful to a patient. A couple of minutes and you have ensured that that patient will not survive. For the EMT regarding capnography, it's easy to think of this as a paramedic skill, when in fact the actual mechanics are very basic. It literally is turning on the machine, turning it to the right position on the monitor, and placing a plastic adapter on the end of the ET tube. EMTs are doing much more advanced care than that. They're doing a lot more ALS assist than that. It's easy for an EMT to really assist the paramedic, and if you're working with a paramedic who perhaps keeps forgetting to use capnography, or maybe the technology is a little scary for the seasoned paramedic. If that's happening, the EMT really has a very strong role here to assist. If they put the adapter on the BVM, then when the paramedic goes to use ventilation, it's already there and you're going to have it immediately. Additionally, the EMTs can be looking at the monitor and keeping the patient's capnographic reading, capnometric reading between 35 and 45. If it goes high, bag a little bit faster, give a couple extra breaths. It goes low, back off that bagging for just a second and see if it doesn't come back to 35 to 45. So the EMT can really use it as an excellent tool as well and help the paramedic that they're providing care with really do a benefit for the patient by watching those numbers and adjusting their ventilatory rates according to the capnometric reading, keeping it 35 to 45.